Good morning and Assalamu alaikum to everybody who's attending this course. The main language that I'm going to speak in is English, although beech mein Urdu bhi dal dunga for certain things and to stress on certain factors. The aim of this course and this talk is not to make you experts in ventilation. It will not make you experts, but what it will do, hopefully, is to take the fear out of those people who will be going into ICU, who are attending patients on ventilators, and it is just an introduction to ventilation. Right, so whatever your questions are, please feel free and we'll address them at the end. So this is my disclosure statement. Right, so what are the functions of respiration? One is to get the oxygen in, and the other is to get the carbon dioxide out. These are the two main functions. And then there are other ancillary functions such as its blood reservoir, a few hormonal functions, etc., etc. But there are two main functions. What are the indications of intubation and ventilation? Respiratory failure is one, and the other is for area protection for those people, specifically for those people who have a low GCS. So what are the type of respiratory failures? There are two types. Type 1 has a low oxygen and type 2 has low oxygen and high carbon dioxide. There is going to be a lot of repetition from our previous lectures, and hopefully these points are to stress on what the problem is. So again, going through respiratory failure, I know there was a talk on respiratory failure in the first session, so this is just a few basic reminders. The criteria for institutional ventilatory supports are well documented. So if you look at the pulmonary function studies, if the respiratory rate is greater than 35, one needs to start thinking on it. Again, these are not written in stone. These are guidelines, and you can see the patient yourself and decide for yourself. It is not written in stone. If it is greater than 35, it is 36, we will tube the patient. Look at the patient. If the tidal volume is less than 5 ml per kg body weight, if the vital capacity is less than 15, and the maximum inspiratory force is less than 20 centimeters of water. The other indication include the blood gases, which is a pH of less than 7.25. Again, I have to insist on this, that don't look at the number, look at the trend and make a differential. If it is because of metabolic acidosis, you need to sort the metabolic component out before you intubate the patient. So it is a multi-pronged approach that we have to take with the patient. If the PaO2 is less than 60 and the PaCO2 is greater than 50, again, be warned with COPD patients, they may have a normal CO2, PaCO2 of greater than 50 with a normal pH. So it's not just one number, but the series of numbers and the whole trend, which we have to take into account. So what are the primary goals of ventilation? It is to achieve a desired minute ventilation, to match the patient's metabolic needs, and to accomplish adequate gas exchange. What's the problem and why do we care? Well, ventilators saves lives, yes, but ventilators are bad. Ventilation is not good at all because ventilator cause barotrauma, they cause volutrauma, they cause atelectrauma. So we have to be very careful. It's not ventilator pe dal diya patient ko and the patient's on the ventilator and everything is fine. No, everything is not fine. Ventilators do save lives, but again, we need to be aware of everything because it causes complications as well. So the basic concepts, we have oxygenation, which means oxygen delivery to the patient, and then the ventilation concept, which is clearing of the carbon dioxide. So for oxygenation, we have the FiO2. FiO2 stands for fraction inspired oxygen. So FiO2 of 1 means 100% oxygen. FiO2 of 0.8 means 80% oxygen. So sometimes it's given in percentage, but sometimes it's given in fractions. So that's why the FiO2. Then we have the PEEP, which is positive end expiratory pressure, and the mean airway pressure. These are for oxygenation, which is oxygen delivery. For clearing the carbon dioxide, we have the tidal volume, we have the respiratory rate, and the combination of these is the minute ventilation. So the tidal volume and rate. The normal spontaneous tidal volume is 6 to 8 ml per kg. Ideal body weight for adults. The normal breathing is 12 to 18 breaths per minute. Again, you have to keep in mind that if someone is young and is very active, they may have a lower respiratory rate. If they're athletes, they may have a lower respiratory rate as well. And normal spontaneous minute ventilation is 100 ml per kg ideal body weight. The ideal body weight is calculated based on gender and height, the frame size. And we have to keep in mind that lungs do not get bigger when a patient gains weight, but a heavier patient does have a higher metabolism and a higher minute ventilation requirement to meet those metabolic needs. So that's why we look at the ideal body weight and not the actual body weight when we're calculating the numbers. So the type of ventilators are two. There's negative pressure ventilators and positive pressure ventilators. The negative pressure ventilators are no longer used. They used to be used previously and were introduced during the polio pandemic epidemic, and they were known as the iron lungs, where the patient's body was encased in an iron cylinder and negative pressure was generated and the body just expanded and the lungs just expanded. So thank God they're not used anymore. So that's aside. Next, we come to the positive pressure ventilators. These deliver the gas to the patient under positive pressure. Great. And this happens during the inspiratory phase. So the respiratory phase is the inspiration and the expiration. Expiratory phase is spontaneous, so we can put that aside. So we only need to worry about the inspiratory phase. So that makes life a lot easier. So out of two things, inspiration, expiration is not, we're not concerned about, which is the inspiratory phase. So only one thing to worry about, which is inspiration. The type of ventilators that we use for positive pressure are volume control and pressure ventilators. There's a third kind, which are high frequency ventilators, but these are beyond the scope of today's program, today's talk, and this program. So, and it's for a higher course for ventilators. So inspiration, and in inspiration, volume and pressure. There is no third thing. So what does volume do? As the name says, volume is controlled. So we set the tidal volume, we set the peak flow or the I ratio, and the respiratory rate. That's as simple as it gets. You dial a volume, I want 400 ml in that one breath. I want an I ratio, expiratory ratio 1:2. Again, we have to keep in mind we are only controlling the inspiration. The expiration is passive and it depends on the elastic recoil of the lung. And then we set the rate, respiratory rate, which is usually 12 to 14 breaths per minute. So we set the tidal volume, the I ratio, and the rate. Three things to set in the volume control. What does it do? Well, the tidal volume that you will dial will be according to the ideal body weight, 6 to 8 ml per kg ideal body weight, and it will deliver that with each breath. The peak flow is the rate at which the volume is delivered in liters per minute, and it controls the inspiratory-expiratory ratio, or you can set in certain ventilators the IE ratio directly. And then you have the respiratory rate, breaths per minute. Please keep in mind that if you make one change or some change in the ventilator, make sure that you look at the other settings of the ventilator as well, because it may change accordingly. For example, you change the peak flow rate, it will change the I ratio. So you want to fix the I ratio. In certain ventilators, you change it directly. In other, you may need to change it indirectly by manipulating the peak flow. So with the volume control, we have the preset rate and tidal volume at a set interval. In this, full mechanical breath is delivered. It is generally used for weak respiratory efforts. It allows synchrony with the patient, but it is not a weaning mode. It is a beginning mode of when to start ventilation. What it does, it gives a consistent tidal volume, irrespective of changing impedance, and it generates auto PEEP as well. The biggest advantage that a minimum minute ventilation is guaranteed. Minute ventilation is respiratory rate into tidal volume. There are a variety of flow waves in the ventilator for volume control, but it's usually a square wave. Disadvantages are that it has variable pressures in the airway and alveolar, and the alveolar pressures are quite variable. It will give a fixed flow pattern. It is a compressible volume, and if there is a leak in the circuit, you will have volume loss. And if the patient gets tachypneic, it leads to excessive minute ventilation. So what does all this mean? Well, variable pressure means that if you deliver a tidal volume of 500 ml, it will deliver the tidal volume of 500 ml, but the area pressures are going to be variable. For example, if you know with the flow tracing that the pressure and flow variability, the pressure is variable with each breath, whereas the flow is consistent, and the flow pattern, that's a square wave, is quite consistent. What you will see in the volume control is a plateau, and this is the plateau, which you will see, which is not seen in the pressure control ventilation. But with each breath, the area pressures will be variable. That's it about volume control. Now we're going to come to pressure control. So in pressure control, we set the pressure limit and the time spent in inspiration and the respiratory rate. So when I say the pressure limit, you have to realize that pressure that we measure is at the end of the ET tube, the endotracheal tube. So if I dial a pressure of 15 centimeters of water, what that will do is it is going to keep on delivering till it reaches the area pressure of 15 centimeter of water. That will be measured by the pressure sensor at the end of the ET tube. Now, if you think about it, what that means is that with each breath, the tidal volume will vary. So the target is not the tidal volume, but the inspiratory pressure. It will tell we will dial and tell the ventilator this is the maximum pressure with each breath, which is the peak inspiratory pressure, which is a combination of P inspiratory and PEEP. So when you're dialing it up, please note that whenever you dial it, you have to account in the PEEP as well. The inspiratory time is either set or constant, and this is again variable with the IE ratio. So you can say, I want this delivered in X amount of second, or you can dial the IE ratio and the computer will do the mathematics itself. And then you put in the respiratory rate in breaths per minute. So you have to realize that for a given peak inspiratory pressure, the tidal volume may be higher or will be higher in pressure control as compared to volume control. The tidal volume in volume control is controlled by us when we dial it up on the ventilator. The tidal volume in pressure control is not controlled by us, but the pressure or area pressures are controlled by us. So look at it this way, that the tidal volume is dependent on the lung compliance. The more elastic the lung, the higher the compliance, the more tidal volume will be generated for a fixed amount of pressure. The advantages of pressure control is that it is more physiological as it has a decelerating flow. The disadvantage is that there is no guaranteed tidal volume or minute ventilation, and this can lead to extreme under or overventilation. So if you look at the pressure and volume tracing, you will note that the flow is variable, but the pressure is constant with these. So the flow, this is the flow, this is the pressure. Pressure is going to be constant and the flow is going to be variable with each breath. So these are the two graphs of the volume control and pressure control. So if you go into an ICU and you look at just the flow patterns, you should be able to differentiate between a volume and pressure. It's not something that to be worried about. A volume control will have a plateau, whereas pressure control will not. So that's one of the biggest things, but you don't need to worry about it. So what if the patient starts breathing? When the patient does nothing, things are pretty simple now. We have the patient paralyzed. So they're paralyzed and patient is not doing anything, but that's not how the patient is going to be. Eventually the patient will wake up, or we will wake the patient up. We will turn the medication off, the sedation off, the paralysis agents off. Please note that you should turn the paralysis agents off before you turn the sedation off. It is very important that you have a patient sedated and then paralyzed rather than paralyzed and not sedated. That would be very, very horrible. So when the patient wakes up, the patient will want to breathe and the ventilator has to figure out what to do. And now we say now we come to the point what is known as the patient triggers the ventilator. I'm sure all of us know what a trigger is. So with flow triggers, it's easier, more sensitive in general, and pressure triggers are tougher to trigger, but less accidental breaths are present. So when I say trigger, it means that the trigger, the trigger on a gun. So the patient is going to make an effort of some sort. This effort will be measured by the flow sensor or the pressure sensor at the end of the ET tube, and it will tell the ventilator that yes, this is the minimum trigger settings that we have. If it is triggered, it will deliver the volume as per setting. If it is not triggered, the ventilator will deliver what it is. Then we come to the pressure support mode, or what is known as the spontaneous mode, or what a lot of people say, oh, the patient is on spont. It's not spont, it is spontaneous. In this, we set the pressure support, we set the PEEP, and the flow percentage cutoff is set in certain ventilators as well. So when a patient triggers a breath, the ventilator bumps up the inspiratory pressure to the pressure support level, and it delivers the tidal volume. The pressure support continues until the flow drops to the set percentage of maximum, whatever you set. So which means that we do not set the respiratory rate. So if you look at the patient flow patterns, you will see that with each triggered breath, you will see a different color or a different triangle marker, depending on which ventilator, which company's ventilator you are using. Some will have a small dot, some will have a small triangle, some will have a small circle, some will have a different colored line, as is apparent in this. But it will show you, it will indicate, the ventilator will indicate when a breath is triggered. Then we come to the SIMV mode. SIMV is synchronized intermittent mandatory ventilation. So it is a hybrid of control and pressure support ventilation. When I say pressure support, I mean spontaneous. So it is a hybrid of controlled ventilation and a spontaneous ventilation. And it is a mode which is used for patient ventilator interaction. The SIMV divides the tidal breath into the mandatory period and the spontaneous period. So if patient tries to breathe through the mandatory time, the ventilator will give a full assessed breath and the same tidal volume is achieved. Whereas if a patient tries to breathe during the TS, the ventilator allows the patient to take the breath, and the assistance is provided with the pressure support that we dial up. And the tidal volume will depend on the patient's effort and pressure support. Now, this is very confusing for a lot of people. So let me explain it in another way. You have set a tidal volume. You set the mandatory ventilation. This is the minimum minute ventilation I want, which is a respiratory rate. And you can either dial a volume SIMV, in which case the mandatory breath will be volume breath, or pressure SIMV, in which case the mandatory breaths will be pressure breath. Now, this will come, if you go back to the previous talks of the previous slides of pressure control and volume control, those are the same things. So the control is for the volume or pressure, whereas the support breath is going to be pressure. So if the patient is not breathing, they will get either volume or pressure, whichever you dialed. But if the trigger, then they will get a pressure support breath. Now we're going to come on another topic which is very important, which is ventilator alarms. So mechanical ventilator comprise audible and visual alarms, which act as immediate warning signals to altered ventilation. The alarm systems can be categorized according to the volume and pressure. High or low, high pressure alarms warn of rising pressures, and low pressure alarms warn of disconnection of patient from ventilator or circuit leaks. If an alarm sounds, please respond immediately, because the problem could be serious. You assess the patient first while you silence the alarm. So a lot of times what people do is silence the alarm and walk away. Please do not do that. Look at the patient, silence the alarm. Look at what the alarm is. If you cannot quickly fix the problem, take the patient off the ventilator. And the patient is not doing well, take the patient off the ventilator, ventilate him with a resuscitation bag connected to an oxygen source until a doctor, a senior doctor arrives. If you are the senior doctor, then, and if you need help, call for help. A nurse or respiratory therapist must respond to every ventilatory alarm. Everything that alarms must be looked at. It's not que alarm baja thoda yaar rehne do. It's okay. It's just an alarm. No, it's not just an alarm. There is a reason that there is an alarm. That means there's something abnormal happening. So alarm must never be ignored or disarmed. Ventilator malfunction is a potentially serious problem. The nurses or respiratory therapists generally perform ventilator checks every 2 to 4 hours. And if there is an alarm which is happening recurrently, they should alert the clinician to the possibility of an equipment-related issue or a patient-related issue. So please note that it is not always the machine which is at fault. There may be some problem with the patient as well. So when a device malfunction is suspected, a second person, again, a call for help is given, and a second person should manually ventilate the patient while the person in charge or whoever is there should look at the cause. If the problem, it cannot be corrected and the ventilator cannot be adjusted, a different machine should be attached, and this machine should be labeled and should be sent to the technical staff or the biomedical staff, whichever is available, or whatever the system in your hospital is. So what are the causes of ventilator alarms? High pressure alarms, if there's increased secretion, there's a kinked ventilator tubing or kinked ET tube, the patient is biting on the ET tube, or there's a lot of excessive water in the ventilator tubing, or maybe it's the ET tube is advanced and has become endobronchial and you're doing one lung ventilation. These will cause a high pressure alarms. Low pressure alarms are generally disconnection, there's a cuff leak, there's a hole in the tubing, or there's a leak in the humidifier. So again, there are alarms. So for each patient, you should be specific for setting the alarms. Then there's the oxygen alarm where oxygen supply is insufficient or is not properly connected. This is a very serious issue. The high respiratory rate alarm, patients will be waking up, they may get episode of tachypnea, they may have anxiety, they may have pain, they may become hypoxic, or when they have fever, again, the body responds by having a higher respiratory rate. There's the apnea alarm. This happens during weaning. It indicates that the patient has a slow respiratory rate and has periods of apnea. The apnea alarm are generally set in seconds, 10, 20, 30, whatever it is, but you should be aware of the alarm settings and you should set the alarms for each patient individually whenever you are putting a patient on a ventilator. So in summary, we should be aware of the dangers of ventilation. We have polytrauma, paratrauma, atelectrauma. Don't get confused with the names that different companies have on different ventilators. We have the pressure and volume. There, as far as I know, there is no third thing that goes wrong, or it's a combination of these. If you cannot understand, open the settings and see what you can manipulate. Either it is a volume or pressure. The ventilation should be individualized for each patient. There is no one formula fix all. It is for each individual patient, for each disease process, at that time, at that place, for that patient. Not ke, this is the fire tha, last time your patient aaya tha, we put it at this, we let put at that. No, they may have different disease processes. Look at the goals and targets of ventilation. What to start with 100% oxygen, FiO2 of 1, and work your way down. Set the appropriate alarms, assess the patient, reassess. Specifically when you're changing, you initiate change, reassess the patient. It may not work, it may not be the appropriate one, you may need to rethink it, and then you reassess it again. And please, documentation, documentation, documentation is very important. In the end, prima non nocere, first, do no harm. Thank you very much. Questions, please.
Thank you, Dr. Fajad, for your talk on basics of mechanical ventilation. There are a couple of questions from the participants which they have asked. One of the question is, what is the full form of PEEP, as you have mentioned in your talk? And they also want to know that how the PEEP helps in the ventilation of the patient.
Right, PEEP stands for positive and expiratory pressure. How does it work? Okay, so you look at a balloon. So an alveoli is like a balloon. If the balloon collapses, it becomes very sticky. And then it becomes very difficult for it to expand again. What PEEP does, it prevents the alveoli from collapsing. It keeps them up a bit high. It keeps them open and prevents it from collapsing. So basically, PEEP gives additional pressure at the end of expiration, keeps the alveoli open, and helps with oxygenation by prevention of the collapse of the alveoli. A higher PEEP is going to put more pressure on the alveoli and keep it more expanded and increase the intra-alveolar pressure, and which helps with oxygenation as well. I hope that answers the question.
The other one of the question is when in pressure controlled ventilation, if patient doesn't reach the trigger, is the pressure not delivered to the patient?
In pressure controlled ventilation, so it's a mandatory mode. It's controlled. If a patient does not trigger, then whatever you have set for the control mode, that will be delivered to the patient. If a patient triggers, then whatever you have set the pressure for the trigger mode, for the spontaneous mode or pressure support mode, that will be delivered to the patient. Generally speaking, both are the same, because with the control mode, at a specific pressure of 12-15, a tidal volume is delivered. So you start with that and you work your way down. And if the patient is triggering frequently, then we move from pressure control to a SMB mode or a spontaneous mode.
One of the question again from panel participant, that other than the parameters you have mentioned in your presentation, how do we clinically decide to put the patient on a ventilator?
Right. So there is no firm fixed fast rule as to when to put a patient on the ventilator. Though a few things that do, so one has to note or keep in mind that, okay, so where are we now? So the other indications, respiratory failure and airway protection. If you think that the patient requires airway protection, you intubate the patient and put on a ventilator. If you think the patient has respiratory failure, and these are the respiratory failures, you put the patient on mechanical ventilation. If there is a metabolic need, then you need to put the patient on mechanical ventilation. But again, assess if it is so bad that the GCS has dropped, then it comes back to airway protection. You need to put it on.
A lot of questions are coming, so
I
think we have to.
Not a problem.
Because we also have a time almost around 5.
That's fine.
We have. The other one of the question is, please explain the lung compliance in easy words. How we can.
Okay, so balloon. The easiest example is balloon. Balloon, in certain balloons or small balloons को फुलाने में आसानी होती है. ठीक है, कुछ बलून होते हैं फूंक मारते रहो नहीं फूलते. लंग भी यही है. Each alveoli is an individual balloon. A combination of all these balloons is what compliance is. Compliance is change in volume per unit change in pressure. आप फूकेंगे अंदर, हवा जाएगी, कुछ बलून जो है जल्दी फूल जाएंगे, कुछ कम फूलेंगे. तो जो जल्दी फूल जाएंगे उनकी कंप्लायंस ज़्यादा है, जो कम फूलेंगे उनकी कंप्लायंस कम है. A combination of all of these. So we cannot measure individual alveolar compliance. We look at the total. We look at the lung compliance, because millions of alveoli, individual numbers से कोई फायदा नहीं होगा. So we look at the lung compliance in total. Lung overall may be bad. So it is going to be stiff lungs. तो compliance खराब होगी. अगर easily expand हो रहा है तो compliance easy होगी. Compliance अगर समझना है, बकरी जब आएगी तो the lungs जो बकरे के निकलते हैं उसमें पानी भर के देख लें, expand होते हुए नजर आ जाएंगे. It's amazing. You should try it. I hope that answers the question.
Okay, Dr. Fajad. Next question: what type of vent mode in ARDS for COVID patient?
Right. So it doesn't matter actually. What to start with does not matter. The thing is that you need to be safe. So कुछ समझ नहीं आ रहा, you can either put pressure or volume. Start with anything. And if you don't know, again, with this course, it's just an introduction to ventilation. There is no way that in one talk I or we can make you experts in ventilation. But what to start with? Volume or pressure. You look at the alarm limits, you look at the normal limits, you start with the FiO2 of 100%, you secure the airway. So you secure the airway, you start with a 100% oxygen. You can put a volume or pressure mode. If you put a volume mode, 6 to 8 ml per kg ideal body weight and airway pressure is बहुत high आ रहे हैं, you switch to pressure mode, you change the respiratory rate. You look at the minute ventilation that you want to measure and you focus on that and you call for help.
Second last question. Okay, there are many questions coming down to us.
No problem.
What is the minimum trigger and criteria for setting the trigger according to each individual patient?
So there is no minimum, there is no maximum, but you need to be aware that the lower numbers you go, the more sensitive it becomes. So for a patient with a hyperdynamic circulation, it is going to trigger more often. For example, thoracic cavity has the lung and the heart. So if the heart is moving like this in the thoracic cavity, every contractile activity of the heart is going to do air displacement. That may trigger it as well. So अगर heart rate patient का 120 है तो हो सकता है 120 का भी trigger हो रहा हो. So trigger settings होती हैं. Generally speaking, कोई magic number नहीं है, but I start with a magic number of 2. That's about it. 2 centimeter water, 2 liters per minute, whatever it is, and work your way up and down. The higher the trigger, the more effort the patient needs to make.
Hope the query will be cleared. One of the question, बहुत सारे social media पे भी videos आ रही थी. One, can we ventilate many patients with one ventilator? What is your thought?
My thought process is that it is not recommended at all. There are a lot of videos on social media for ventilating for multiple patients, but look at it this way. All societies have not recommended it. The reason is that each patient has their own compliance, their own problems. So, दो balloon जब एक जैसे नहीं होते, we're expecting कि एक patient, same with दो patient एक जैसे नहीं होते. Each patient will have a different compliance. So unless you have individual set controls for each patient at the inspiratory limb, which will control the inspiratory pressure and expiratory volume individually, there's no point. The chances of causing damage and patient harm and patients dying is more than the benefit. This concept has been around since the 80s, and it has been published in Pakistan as well. There's a paper published by Brigadier Salim as well with diagrams. And if it hasn't taken on in the last 30 years, I don't think it is. I would not recommend it. I do not think it should be used. Using one ventilator for multiple patients is not recommended at all.
Okay, sir. As already Dr. Fajaz said that no society have recommended that multiple patients can be ventilated on a one ventilator. One of the question, I think this is a basic question. So people ask, every person is talking about proning, and awake proning. The question is what is the logic behind proning a patient in ARDS?
Right. So if you look at the cross-sectional view, the lung is like a triangle. This is, when we're setting up, it's like a triangle, apex over here and the base over here. If you're lying down flat, it is like a triangle over here. So at the back, we have the more alveoli. So generally speaking, fluid works with gravity, it settles down. So when you prone the patient, it becomes an inverse triangle. So more alveoli are opened up over there, and it tends to, the fluid tends to go down, settle down at the apex. What also does is that with ventilation, with air tends to rise, and we tend to open more alveoli at the base rather than the apex. That's as simple as I can explain it.
The last question, sir. I couldn't understand the difference between volume and pressure ventilators. You have mentioned in your presentation. Can you please explain it again?
Right. So in volume, we set the volume. मुझे 400 ml volume deliver करना है patient को, and it will be delivered. In pressure, we set the pressure limit, the airway pressure, which is measured at the end of the ET tube. I want the ventilator to keep on delivering air until the peak airway pressure reaches to whatever you said, 14, 15, whatever it is. So with volume, tidal volume is guaranteed. 400 ml will be delivered with each breath, or 500 ml, whatever you dial up. With the pressure, the tidal volume will vary with the compliance, but the airway pressure will not change. It will keep on delivering the air till it reaches a peak inspiratory pressure of, let's say, 15 or whatever you have dialed up. आपने 15 dial up कर दिया, 15 तक आएगा. अब उस 15 को reach करने में it delivered 300 ml in one breath, 350 in another breath. Whereas with the volume, you have the volume fixed. 400 ml अगर आपने fix किया है, I will deliver 400 ml. The ventilator will deliver 400 ml. It will not deliver 450. The problem is then कि airway pressures vary करेंगे with each breath. I hope that answers and makes things easier.
Thank you, Dr. Fajad. Actually, this is a huge topic. We have actually covered only the basic mechanical. The questions was also sometime I have tried to stick to the basics of the mechanical ventilation. वही question पूछे जाएं जो कि
This is the mechanical ventilation.
So, thank you, sir.
You're very welcome.
Thank you.
Thank you very much.
Thank you.